Thank you to everybody for joining the webinar today. I'm John Muscaderi. I'm the scientific director for TVN. So this is one of our monthly webinars, and today's webinar is on priorities for improving end-of-life care in Canada. The webinar will be delivered by John Yu. And so before I introduce John, just to let you know that all these webinars are archived on our website, and this one will be available in the next couple of days. But all the previous webinars that have been conducted thus far, and they started last October, so I think we're on the 5th webinar. They're all on our website for later viewing. So just to introduce John, if I can get my slides to advance. Okay, so John Yu is the theme lead for improving end-of-life care and advanced care planning within TVN. He's an internist at Hamilton Health Sciences Center, associate professor in the Department of Medicine and Clinical Epidemiology at McMaster. He's a member of Clarity, which are the Clinical Advances Through Research and Information Translation Research Group at McMaster, an adjunct scientist at ISIS, an executive member of CareNet, and his main research areas are in improving the quality of end-of-life communication, decision-making, and care for seriously ill elderly patients and their families. So John is very qualified, and we'll look forward to his webinar today. Just from a housekeeping point of view, please submit all the questions that you may have during the webinar online. At the end of the webinar, we'll answer as many of the questions as possible. So without further ado, and just the last is that we have two upcoming webinars. Just want to alert you on is that are listed on the screen. Webinar on April 1st is on improving acute and critical care, and that's by Paul Hebert, and a webinar on May 6th, which is choosing healthcare options by involving Canada's elderly, and that's by Paul Stoley from University of Waterloo. So please tune in for those upcoming webinars. So without further ado, I'm going to turn it over to John for his webinar today.
Thank you very much, John, for that kind introduction. I'm just going to get my screen to share and the slides up. Someone can confirm on the other end that you can see my slides. That'd be great.
Yep, John, we can see your slides.
Perfect. So it is really a privilege for me to have this opportunity to speak with everyone in this virtual forum. I do look forward to the questions and discussion that follows, so I intend to speak for about 30 to 40 minutes and leave a good portion of time for an interactive discussion. So the talk is entitled Priorities for Improving End-of-Life Care in Canada, and I thought many of you on the webinar may already be familiar with TVN, but for those of you who are less familiar, I thought it would be helpful just to give a bit of background, and then I'll go into the objectives of this talk and through the material. So TVN is a federally funded network of centers of excellence that is currently about midway through its first 5 years of existence, and it has a number of research priorities that are depicted here, but it is all around trying to match care to values for seriously ill, frail elderly in Canada, and to improve care for this very important population in our country. And to do this, TVN has articulated several key research themes that are listed here on the right. Improving end-of-life care and advanced care planning, which is the theme that I'm charged with leading and which I'll speak about today, but also other themes in the area of acute and critical care, community and residential care, and then of course optimizing the transitions of care between these settings. With respect to the first area of focus, research focus for TVN on improving end-of-life care and advanced care planning, I thought it might be helpful for people on the line just to get a sense of the research portfolio within this theme for TVN and what's already been done or what's currently being done by TVN network investigators in this area of end-of-life care and advanced care planning. And so the range of projects, I'm not listing them individually here, but just to give you a flavor of the work, the range of projects has been broad in terms of some projects being done at a sort of population health services research level, for instance, looking at patterns of end-of-life care and health resource use in the last 1 to 2 years of life across Canada to really provide foundational descriptive data to understand the current context. There have been other projects that focus really on providing end-of-life communication skills training for clinicians, and by clinicians I don't mean just physicians, across a number of different care settings. There are projects that have focused on information technology, for instance, how to benchmark best practices in end-of-life care using EMRs in primary care as a way to improve the quality of end-of-life care in that setting. And then there's been actually quite a large collection of funded research projects that look at either the development or the implementation and evaluation of different decision support tools to help patients, family members, and clinicians communicate better and make better decisions about end-of-life care in a variety of settings, including in the primary care setting, in the hospital-based setting where I work, as well as in long-term care. So that's just to give you a landscape of what TVN has been doing to date in this within this theme. What I'm going to talk about for the next 30 minutes or so really is at a fairly high level from a Canadian perspective in end-of-life care. Where have we been from a research perspective and a care delivery perspective? Where are we now? What are some of the issues we're grappling with, and what are the hot topics for discussion, and importantly, where do we need to go in the future to improve end-of-life care and advanced care planning for Canadians? And so certainly a lot of it will focus on articulating research priorities, because I do have a background as a clinical researcher, but I think there are also many issues beyond research that need to be achieved to improve end-of-life care in Canada. So I'll touch on those as well. In terms of my perspective and where I'm coming from with this, as John mentioned in the introduction, I am coming at this from a perspective as a hospital-based clinician. So I'm a physician, a general internist, and I'm a clinician researcher. So I do have a strong interest in improving end-of-life care, and in particularly improving the quality of end-of-life communication and how we make decisions for seriously ill, frail, elderly patients, particularly in hospital, because that is the care setting I'm most familiar with. So I think it's helpful to know, as you hear the rest of this presentation just what my vantage point is, provide you with some context on that. And certainly, when we think about improving end-of-life care, advanced care planning for Canadians, there's a lot of care settings that are important, primary care, long-term care, and community-based care. But I would say, given my personal experiences in the hospital, that hospitals are, in fact, a major provider of end-of-life care. And I think that's largely unrecognized by clinicians working in the hospital sector, because that was not the original mandate of hospitals when they first came into existence. But the reality is that there are many, 250,000 deaths per year in Canada, and the reality is that most Canadians still will die in a hospital bed, approximately 60%, although this varies a little bit from jurisdiction to jurisdiction. It is about half of Canadians that will die in a hospital bed. And as much as we want and will likely achieve a shift in location of death away from hospitals and into more community-based settings, I think it's always going to be inevitable that people will require hospital care near the end of life, no matter how hard we try. So I think it will be important for hospitals going forward to really acknowledge and embrace this aspect of the care they provide. And this is in contrast to, when I talk about where have we been and what were things like in the past. This is a picture of the death of George Washington, first President of the United States. And if you read the accounts of his death, he got sick on a Friday and died on the Sunday after a few days with an infectious disease. And also you'll notice here that he's not dying in a hospital setting, but in a home-based setting. And so I think the nature of dying has changed tremendously over the last few generations, where in the past people just got sick and died, and it was quite a short-lived event, the dying process was. But now, because of the advent of new treatments and therapies and devices, which have been very good developments, it's also created a much different trajectory of dying and a much different pattern for how we die in industrialized countries in the world, including Canada. So that on this graphic, in fact, the majority of people, approximately 2/3, will not die a death such as George Washington's, which was a relatively sudden death in the top left corner, but rather 2/3 will die a much more prolonged death, such as the two trajectories that are illustrated in the bottom half of this graphic. Organ failure, which would be something like congestive heart failure or chronic obstructive lung disease, is really a process that is chronic in nature and where there are lots of ups and downs in terms of function and health status, with an overall downward trajectory, but that's stretched out over months or years. And then there are patients with dementia who may live for a very long time, many years, in a state of substantial frailty. And I think our models of care and our health systems really haven't fully adjusted to this new reality. We have a health system that is still very heavily hospital-based and has a lot of resources in that sector, which were really designed to provide episodic care for people with a discrete illness, for example, an inflamed appendix or a fracture. But I don't think that our system has fully yet evolved to meet the challenges of these new trajectories of dying amongst seriously ill, frail elderly. If we look to, we fast forward a bit from George Washington and think about the Canadian landscape as it relates to end-of-life care, the modern hospice palliative care movement is recognized to have started in the UK with the work of Dame Cicely Saunders in the 1960s. So in Canada then, in the mid-70s, which really isn't all that long ago if you think about it with a long view, in the mid-70s was the beginning of the modern palliative care movement in Canada with the establishment of the first palliative care unit at St. Boniface Hospital in Winnipeg, and then very shortly thereafter, the Royal Victoria Hospital in Montreal. Since that time, the movement has become more organized with the development of professional societies and other organizations, and then most recently, important documents regarding end-of-life and palliative care at the federal level, so reports from the Senate led by Senator Sharon Carstairs, articulating sort of the needs and the opportunities and the gaps in end-of-life care in Canada. And I would say that in these, what I would still call early years of thinking about palliative end-of-life care in Canada, I would say that really a lot of the focus, and this is true of not just Canada but much of the world, has been on the provision of palliative end-of-life care for patients with terminal cancer, which I think was a natural fit and a very big need, but that there has been less focus until more recently on the needs of patients with non-cancer diagnoses who may have chronic illness or sometimes multiple chronic illnesses, and thinking about how do we best provide end-of-life care for that large population of patients. The support trial, which was a landmark clinical trial based in hospitals in the United States in the 1990s, I think really did help to put on the map some of the issues related to providing good end-of-life care beyond the terminal cancer setting. This was a study that really looked at first describing and then trying to improve end-of-life care for seriously ill, frail, elderly patients in hospitals, the majority of which, approximately 85%, did not have cancer diagnoses. And this was a landmark study that contributed some really important findings. First of all, to show lots of unmet needs for seriously ill, frail patients in hospital as it relates to end-of-life care and end-of-life decision-making. So, for example, problems with very, very late documentation of resuscitation status before the time a person died, and the lack of alignment between patients' values and preferences with the care they actually received, and the inadequate treatment of pain near the end of life were all key findings from the first phase of the support program of research, which was a descriptive phase of research. And then the second half of the support program of research was an attempt to actually intervene with a sophisticated intervention to improve the quality of end-of-life communication and decision-making and care for this population. And for a negative trial, which didn't show any impact on their desired outcomes, the study certainly did have did garner a lot of attention and really did serve to highlight the importance of the issue in the healthcare community at that time. So I wanted to spend some time talking about this trial because it was really a turning point in the whole field of end-of-life care in North America. If we think about research in Canada as it relates to end-of-life care, there has been support at the federal level for this work prior to TVN becoming involved in the last few years. So in particular, thinking about CIHR, which is now undergoing changes, but in the past, there has been a palliative end-of-life care review panel for operating grants, and through that mechanism, there was a way to support clinical research in end-of-life care in Canada. And then, importantly, not too long ago, in the early 2000s, there was a specific new emerging teen grant program from CIHR that looked specifically at end-of-life care in Canada. And over that 5-year period, there were a number of different teams that were funded to look at a range of issues, including family caregiving, cancer-associated cachexia and anorexia, provision of end-of-life care to vulnerable populations, and then work that looked at how to improve communication and decision-making at the end of life. And it's that latter group, that latter team, that was the origins of the Canadian Researchers at End of Life Network, or CareNet, of which I am a member. And so certainly through CIHR, there has been some important work done in the Canadian context that's provided important insights into what I'm going to talk about today, which is what are the priorities for future research in end-of-life care and advanced care planning in Canada. So I will spend some time now talking about the foundational work that was done by the CareNet group in Canada to provide some of the foundation for what I believe are important future priorities for end-of-life research in Canada. So this is a important paper that was published by a colleague of mine, Dr. Darren Hyland, who was the founder and continues to be the scientific director for CareNet. This paper was published in the Canadian Medical Association Journal in 2006. And it really was an attempt to directly engage seriously ill, frail elderly patients in an exercise to understand from their perspectives, as well as from their family members, what constitutes high-quality end-of-life care from their perspective. And so several hundred frail elderly patients in Canadian hospitals were administered a questionnaire in person by research staff to elicit these perspectives. And what the results showed of this multi-center survey were the following items. So these are the items that were rated as extremely important by the participants in this project. Things like having trust and confidence in the physician looking after you, and not being kept alive on life support when there's little hope for meaningful recovery, receiving honest communication about their illness. In short, the things that seriously ill patients and families valued most when thinking about end-of-life care more broadly really were issues related to good end-of-life communication and decision-making. In a follow-up study, in the same population of seriously ill frail elderly in hospitals, the same research group asked the same population of patients, what are the issues that are, number one, really important to you and that you are least satisfied with, to try to identify priorities for action in terms of quality improvement. Where are the opportunities where we can make the biggest impact and the biggest difference? Well, those would be areas identified by patients and families as number one, important to them, and number two, the areas that they were currently least satisfied with. So this was published in CMAJ in 2010, and what it shows, I won't show all the data, but what it concluded are that many of the priorities for patients in hospital around end-of-life care in Canada, again, relate to aspects in better communication and decision-making about end-of-life issues. So very clearly, frail elderly in Canada are asking for improvements in the way that the healthcare team communicates about end-of-life care and engages them in decision-making. If we now shift gears to where are we now as it relates to end-of-life care in Canada and in North America and more broadly, there's the concept of advanced care planning, and this is part of the theme in TVN that I represent. It's the end-of-life care advanced care planning theme. And certainly the notion of advanced care planning has gained a lot of traction in the past decade. So this is a graphic just showing you the number of publications that are coming out each year where the major subject heading is advanced care planning. And you can see there's been a very steady increase, and we're now at essentially about 5 publications per week, or 1 per day almost, on the topic. And the term advanced care planning has gotten a lot of traction in a number of different arenas, and I think to an extent is starting to supplant, or at a minimum complement, the earlier notion of documents and advanced directives that were perhaps the first attempt of our society to give patients or individuals a way to express their future wishes. And I think the modern concept of advanced care planning that has been put forward really centers not around the creation of documents, although these written documents that articulate future wishes can be helpful. What advanced care planning is really all about in its current formulation is about individuals communicating or talking to the people that are going to make decisions on their behalf in the future, since many of us will not be able to make decisions when we're really sick. And to make sure that those people who are going to speak for you have actually had a chance to hear from you about the kinds of things that are important to you. In other words, what are your values? And what would your wishes be when considering treatments near the end of life? Because it's those conversations that may be the most powerful information for future surrogate decision makers to have when there is an actual medical decision to face. And so that is a concept that's been articulated by many experts, including this group here led by Dr. Rebecca Sidori in the United States and Terry Freed, which is all about reframing advanced care planning as preparing future surrogates for end-of-life decision-making. I would also take a moment now to point out to you and to articulate a lot of conceptual work that we've done as a research group within CareNet to delineate some important similarities and also differences between the advanced care planning process, which I just talked about, and which falls under the larger umbrella of end-of-life communication and decision-making, but also to now bring up a related concept called goals of care decision-making, which occur in the moment. And so how is that different from advanced care planning? Because I often find that when talking to colleagues who are all interested in this general area of quality improvement and research, that the term advanced care planning will be used to mean a lot of different things. But I think it's helpful to conceptualize 2 different and related processes. So the first one being advanced care planning, which I just talked about, which I think could be best thought about as a more upstream process that occurs, for example, before a hospitalization or before an actual episode of illness, which is a discussion about future care, meaning that the conversation is going to occur out of context of an actual illness and is going to be more abstract, and so it will be a higher level conversation about wishes and values and preferences, but wouldn't necessarily be discussions about treatment in the moment and wouldn't be decisions about consent for treatment within the context of an acute illness. When we use the term goals of care decision making, that is more what I'm talking about in terms of in the moment decision making in the context of an acute episode of illness, for example, in hospital. And so ideally, a well-done advanced care planning process can be very, very helpful to inform those goals of care discussions and goals of care decisions that need to happen in the moment, in context, for example, during an acute admission to hospital or ICU. And of course, this whole process of communication and decision making is supported by a good process of documentation. So what I'm going to now share with you are some very recent findings from Canadian research that highlight current gaps in end-of-life communication decision-making, and which do highlight some priorities for future work to improve the quality of end-of-life care in Canada. In a multi-center audit that the CareNet group conducted at Canadian hospitals, recognizing the value of advanced care planning, the audit really aimed to understand what is the current quality and quantity of advanced care planning and goals of care discussions amongst seriously ill hospitalized patients in Canada. And what the audit found was that, in fact, when you talk to very seriously ill patients in hospital, most of them have actually thought about the kind of life-sustaining treatments they would want, including resuscitation. And that the majority of the patients that have thought about it have actually talked to someone about these issues. And yet, and when you look at what their preferences are, the majority don't prefer a care plan that includes CPR, only 12% do, whereas the majority prefers some kind of limitation on life-sustaining treatments. What was disturbing was the extent of discordance between what patients wanted in terms of life-sustaining treatments and what the documented goals of care were in the chart at the time that patients were asked. So you can see here that many times prescribed code status in patients' charts at the time of the research interview were for CPR and full resuscitation, whereas not nearly as many patients, in fact, wanted that. And so why is there this degree of disagreement, substantial degree of disagreement between patient preferences and prescribed goals of care? In follow-up analyses of this data, what we found is that if you look at a number of important communication processes, such as talking about prognosis or asking patients what's important to them, asking them about their preferences for care, in fact, patients and families report that their care providers in hospital very infrequently discuss these important issues with them. And so it's perhaps not a surprise that there's that misalignment that we saw on this earlier slide between preferences and prescribed orders. And yet we did find in this work that if more of these process items in terms of goals of care discussions were conducted, there was in fact greater concordance between patient preferences and prescribed goals of care. So that again suggests that to improve end-of-life care and decision-making in Canada, we do need better and higher quality communication between healthcare teams and seriously ill frail elderly across all care settings, not just hospital. And so, is this achievable? Because I did talk about the support trial 20 years ago that tried to improve concordance between patient preferences and actual treatment received, and the support trialists were unable to do that. So what makes us think that we can move the needle now, 20 years later? And I'd like to be optimistic about it, and I do think that the current social context in Canada and North America is very different from 20 years ago. First of all, there is a very real changing of our demographics, which I think are bringing the issue to the forefront. Secondly, I think there's no question that there's a much greater openness to discuss issues around end-of-life care in the media compared to 20 years ago. And there's almost not a day that goes by without reading about an end-of-life issue in the national press. And I think there's also been a tremendous amount of policy attention from many different organizations at many different levels of government about how we should improve end-of-life care within our society. So I do think we're in a different era, and I do think that the time is right for us to be able to make meaningful change. So to close off kind of the formal part of this presentation and then open it up for discussion, I'll just offer some thoughts based on this view of the past and present about where do we need to go in the future. So first of all, I would bring to your attention an important body of work that was conducted by the Canadian Academy of Health Sciences 2 years ago in the fall of 2012. This is a group of the country's best and brightest scholars and clinical researchers who deliberated on the issue of end-of-life care in a forum called The Last 100 Days. And during that dialogue, they were able to articulate some priorities for improving end-of-life care in Canada. And those were the following. So first of all, referring to that blue and red bar graph with the discordance between what patients want and what they are actually receiving, you know, the Academy stated that narrowing gaps between end-of-life care that patients prefer and what they actually receive should be a national priority. In a sense, as a means to that end, that the quantity and quality of advanced care planning and goals of care discussions need to be improved. So calls for better communication and decision-making at end of life. Also, they fully recognize the role that family caregivers play in the care of the seriously ill, frail elderly, and called for an acknowledgement of their role and ways to support them in this role. And then finally, a call for physicians, and I would argue not just physicians, but all clinicians in training, needing more and better education about palliative care and end-of-life communication, because the reality is that there will never be enough palliative care physicians in Canada to provide, to meet all the needs in terms of end-of-life care for Canadians, and so there is, they have called for, and I would agree that there is a need for better education around palliative end-of-life care amongst all healthcare providers during their formative years. The United States, soon after, so this was in the fall of 2014, so about 6 months ago, also had a similar process of deliberation amongst a non-partisan group of experts in end-of-life care to make their recommendations. So this is coming out of the very esteemed Institute of Medicine in the United States in a report called Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life. And many of the issues that they focus on in their recommendations resonate with the priorities articulated by the Canadian Academy. And those are, again, issues related to improving advanced care planning and the communication process between clinicians and patients, looking at better education and development of skills in palliative end-of-life care amongst healthcare professionals. And also they look at issues related to care delivery and policy changes to better encourage clinicians and healthcare providers to do the right thing. And then finally, an important issue that wasn't mentioned in the Canadian Academy report, but which is acknowledged in this report from the Institute of Medicine, is the idea about public education and citizen engagement, and what I would view as culture change to normalize conversations about death and dying, and to acknowledge that this is just as much a part of life, and to encourage more dialogue around the issue. So those are recommendations coming from very highly esteemed bodies in both Canada and the United States. I think I'll skip over these slides and just talk about, from my own perspectives, based on everything that's been presented so far, what are my thoughts from my vantage point about where we need to go in Canada to improve the quality of end-of-life care and advanced care planning. And I think because end-of-life care is such a complex issue, certainly not the same as giving a pill to treat high cholesterol, it really is a complex social issue that involves numerous stakeholders and that spans the healthcare system. And because of that, I think that any strategies as we go forward have to be active on a number of different levels, and there is no single intervention or no single strategy that is going to move the needle. And so, in my view, there are important things that we need to do at all the levels that are articulated on this slide. So at the level of patients and family members, at the level of clinicians, at the level of the health system, and at the broader level of the citizens and the public in our society. And so what do we need to do for patients and family members? I think it's been shown in quite a bit of prior research that advanced care planning does have benefits and is recommended by many expert groups. I think the issue is how can we in fact increase the level of advanced care planning amongst patients and family members. There has been state-of-the-art systematic reviews that have looked at this, and what they found is that there are a number of tools that are available, many of which in fact are web-based tools. Some of them are proprietary, some of them are not, but the big issue is that there has been very little empirical evaluation or study of these tools to see which ones in fact work and which ones work best under what setting. So in terms of priorities for the future, I think there is a lot of work that needs to be done about how best to facilitate advanced care planning for patients and family members. At the clinician level, and this would especially involve clinicians in training, I think there definitely is a huge need for more and better training for clinicians in palliative care practices and in end-of-life communication in particular. Certainly my experiences from my research and anecdotally as a clinician tell me that a lot of clinicians still are not that comfortable talking about death and dying and just aren't sure how to broach these issues with patients and families. And I think we do need better training. And the encouraging thing is that Canadian investigators are working on developing these sorts of curricula. There are, in fact, organizations in Canada, such as Pallium, that are trying to provide better training around end-of-life communication. And there are also high-profile expert groups in the United States that are developing curricula for communication skills training. So I think we do have, I think the time is right to really advance the way we train clinicians in palliative end-of-life care in their formative years. At the health system level, I think there are a number of things that need to happen. One is sort of a care delivery issue. There has been evidence in a number of different settings that an earlier integration of a palliative approach to care can improve outcomes for seriously ill, frail elderly. And the challenge is, I think, at the policy system delivery level, or perhaps the system financing level, how can we put in place the right structures and reimbursement mechanisms to actually make the earlier integration of a palliative approach to care a reality? I think the other thing about the health system is that, although selfishly for me, I would like to see continued efforts made to improve the quality of end-of-life care in hospitals, and I do think that hospitals need to embrace this aspect of care. I think it is also very important that we start to look at how we can invest more resources in other sectors of the health system where traditionally there's perhaps been not as much investment in quality improvement, innovation, and clinical research. So for example, in home care, or in Ontario in the CCAC sector, or in long-term care, I think there is a huge untapped potential to really improve end-of-life care in those settings. And I know there are a few individuals who are doing outstanding work in those settings, but I think we need to see more of that work happen in the future, because those are going to be key sectors going forward in the provision of end-of-life care in Canada. And then finally, at the population level, at the public engagement level, I do think we need to find ways to change the culture and to move us away from being a death-denying society to one that embraces dying as a natural part of the cycle of life, to encourage more open and productive conversation about the issue. So I do think we'll need concerted efforts from many different people to improve this important aspect of care. And I think I'll close with this very nice quote from my friend and colleague Deborah Cook and Graham Rocker, who said, "If we needed a cause to unite us all, improving end-of-life care should be that cause." So I'll stop there, and I think we have 15 to 20 minutes for discussion now.
Oh, thanks, John. Very informative talk and certainly thought-provoking. We've got about 10 minutes for questions, so I'll read some of the questions we've received in no particular order. The first one being, it sounds like the U.S. is having similar issues with respect to ACP and end-of-life care. What countries can we learn from outside of North America in terms of best practices?
Great question. So I think the two jurisdictions, Canada is actually, in my perspective, having interacted with international folks, Canada is amongst the leading edge when it comes to advanced care planning. I would say that the two other jurisdictions that are also at the leading edge, or perhaps even a bit ahead of us in Canada, are the United States for sure, and the UK. Advanced care planning has gotten a lot of traction in the United Kingdom, and they've got a lot of very good initiatives happening there. Europe is coming along, although it depends which area of Europe. I know there are efforts to sort of up-regulate advanced care planning in Europe, but I don't think they're necessarily quite as far along as North America. There is also a group of individuals in Australia that are doing work in advanced care planning. That would be my perspective. But they're all facing similar issues, and I don't think that any jurisdiction has really found the solution for how to really get advanced care planning happening at high levels.
Okay, thank you, John. Another question here. Although the focus has been on increasing the number of people dying at home, both by healthcare planners and patients, Is there any information that this results in better end-of-life care, both from a patient and family perspective? Does it reduce resource utilization? Is there the risk that it actually worsens the experience?
I think that's a really important question. I think what's maybe being implied by the question, and I would actually agree, is the idea that home death does not necessarily equal high-quality end-of-life care. I think there is this notion that if we can increase the proportion of deaths at home, that this means that we're providing better end-of-life care in Canada. And I'm just not sure that it's as simple as that. I think there are a lot of people who say they would like to die at home if they could, but that assumes a lot of things. And as I was alluding to at the beginning of my talk, I mean, I think we're going to try to have more of the dying process occur in a home setting, because for sure there are some advantages to that. But I think the hospital sector and long-term care sector are always going to be really important providers of end-of-life care. And I don't think it is right to assume that number of home deaths is a good indicator of end-of-life care. And the issue of cost effectiveness, I think that's an issue that TVN perhaps will need to address in its upcoming 5 years. Does that actually translate into better resource utilization or not?
Thank you, John. Another question from our audience. Physicians are not engaged physicians are not engaging their patients in ACP or even goals of care discussions effectively. There are many barriers to this for physicians. Can you comment on what you think are some of the biggest and most important barriers to physicians engaging in effective ACP with their patients? Is there any research into these barriers that you are aware of?
Wow. So that's so we actually just, it seems like a planted question or something. we just published a multi-center survey of hospital-based clinicians, so physicians and nurses, where we directly asked them exactly that question. What are the most important barriers that prevent you from discussing goals of care with your patients? And interestingly, and it's a bit the limitation of the study, it was published in JAMA Internal Medicine just a few weeks ago. I mean, what the clinicians said is that it's a lot of issues related to patients and families not being ready to let go, not being able to accept a poor prognosis, or disagreements amongst families in what should be the goals of care. So it almost comes across as the clinicians pointing the finger at patients and families as, in quotation marks, the problem. And while I think certainly one aspect of what needs to be overcome is, getting patients and families to participate in more advanced care planning proactively and to talk about values and preferences, what I think is interesting about the survey we did is that it seems like the clinicians maybe aren't that willing or may not have as much insight into their own needs for developing skills in communication and decision making. And certainly some of the qualitative research that we've done that complements the survey that we just completed would indicate that there are needs amongst clinicians for greater confidence in how to engage in these conversations. So that's why I was saying in my earlier slide, I think we do need multi-pronged solutions that address not just patient and family issues, but clinician needs as well.
Excellent. Thank you, John. So we have time for one last question, and that being, on a practical basis, how can we narrow the gap between what patients prefer and what they receive? Is this better training? Is it system changes, including forcing functions to make sure that it happens?
Yeah, so I think it'd be very attractive, but probably too optimistic to think that there could be just a single. If there's one thing we could do, what should it be? I really do think that it's going to have to be on multiple levels. But I think one of the biggest issues really is that last bullet point on my second last slide about culture change. Like until all of this becomes much more normalized to really for it to be acceptable to think about death and dying and to proactively plan for it, I think it is going to be somewhat difficult to move the needle. And so that's not going to require only research activity, but also we have to think about how do we create social change. And maybe I'll leave you guys all with that big question mark.
Thank you, John. John Muscadere, would you like to close the webinar session?
Sure. So thank you to John Yu for the informative discussion. Obviously, this is a very important area going forward. It's becoming an increasingly big problem as the population ages. It's an experience that, unfortunately, all of us will have to go through at some point. So, and it's an area that TVN is intensely interested in and focusing on, and we're fortunate to have John as the theme lead. And thank you again for the presentation. So just to end the webinar, please keep in mind our next two webinars, which are occurring in 1st of April. Usually these webinars are the first Wednesday of each month. So the first one is occurring on April 1st on improving acute and critical care by Paul Hebert, and the second one that's upcoming is May 6th by Paul Stoley on choosing healthcare options by involving Canada's elderly. Please feel free to distribute the notices to these webinars as broadly as possible, and please refer back to them on the website. They're all archived there. So just to end, thank you to everybody for attending and taking time out, and please be aware of further TVN initiatives in this regard as we go forward. And thank you for your engagement. And with that, we'll end.